So, do you want to be a general surgeon? Well, do you have superhuman bladder, the patience of a saint, steady hands, selective hearing for those annoying patients, and an emergency snack stash? If so, then general surgery might just be for you. Surgery is one of the four main pillars of medicine, being pediatrics, OBGYN, medical, and surgery. The ultimate value of general surgery is the instantaneousness of the results. Look, this patient has an abscess. He's in severe pain, and guess what? With simple incision and drainage, he goes home tonight without any pain. This lady has a chronic fat intolerance. Oh, she has gallbladder stones. Boom, one day surgery, she goes home after lab chole, treating her condition, and now she can enjoy a lifetime of fatty food. This lad has inguinal hernia affecting his private time. Boom, one day surgery, hernioplasty, he goes home, no problem. Keep in mind, this goes both ways. Fast rewards also means fast complications. Hey, look, during right hemicolectomy, the surgeon cut a loose, seemingly unnecessary band. The patient can't urinate anymore because that was his ureter. Or during a routine lab chole, this surgeon accidentally stretched the cystic duct too much. Now this patient has CBD injury that requires a very long and stressful procedure. What I'm saying is fast and big rewards, but also fast and big complications. But unlike other specialties, if you're a good surgeon, you will be known globally, not only in your local area, but literally all over the globe. We often hear that we know a doctor somewhere who treats back pain like no other, or this doctor can alleviate the symptoms of diabetic foot without amputation, or this doctor can treat obesity by very good sleeve gastrectomy or whatever. So, reputation for a surgeon is actually something that spreads like wildfire. And on the other hand, if you're a bad surgeon, then you're just simply a bad surgeon. You still get paid, you still perform surgeries, but you're simply not well known. It's like having an ultimate superpower. On one hand, you get to be very rich, very famous, and save lives. On the other hand, you're the one who get called at 2 a.m. because somebody decided to swallow a whole set of car keys. Get it? Good. Now let's look at your daily routine. To understand it better, let's look at Bill. Bill is a general surgeon working in Vancouver Central Hospital. He comes to work every morning at 7 a.m. with a cup of coffee in hand, not because he likes coffee, but other people need him to have coffee. The general meeting starts at 7:30, and it takes around half an hour or so. In these meetings, we discuss common issues, common cases, and if Bill has any admissions last night. What do we mean by admission, you ask? Well, I'll tell you. You see, Bill has an on-call every third day of the week. When he is on call, if a patient comes to the emergency department with a surgical issue that requires surgery, the patient has to be admitted into the hospital, meaning the patient goes from being in home to in hospital. So he sleeps in the hospital, he gets treated, and then he goes home. And the admitting physician is the one who's responsible for the patient while they are in the hospital, who happens to be whoever is on call that day. So when Kate comes with incarcerated hernia during Bill's on call, he's the one who admits the patient under their name, and he's the one responsible for this patient until they're discharged. So during the meeting, Bill is informed that he has one admission last night, which is incarcerated hernia, a patient called Kate. After the morning meeting, Bill goes around the hospital to do their rounds, which is basically reviewing every patient he has under their name, examining them, reviewing the medications, addressing their complaints, and updating the treatment. One important thing to do in the rounds is dressing, which is a key feature in surgery. You see, sometimes we open a wound and we keep it to heal by secondary intention, meaning no sutures, leaving it as is, and it will heal slowly. This is the case with most infected wounds. So if a patient comes in with a large abscess, we open the abscess, we clean it, and we do dressing for the abscess every day until it heals from the inside out by secondary intention. No sutures, and we don't close the wound. By keeping it clean, it will close by itself with time. However, we do need to open the wound every day or every other day to do dressing, which is washing the wound, removing any infected or dead tissues, maybe taking a swab for culture, and then packing and closing the wound again. This dressing part is actually very tedious and it takes a lot of time. It's not very pleasant, but it's like the obstetric part of the OBGYN. You need to do it, it's unpleasant, but it's part of the job. Now, while Bill is doing his rounds, everyone else in the hospital is also doing their round. So this orthopedic doctor who is admitting his patient for fractures has consultation for Bill, which means one of his patients has a surgical issue that a general surgeon can treat. In this case, the patient has a swelling in his forehead that he's had quite some time. So he called Bill. Bill saw the patient as a consultant. He diagnosed the patient with superficial lipoma, which requires non-urgent surgery. So he gives the patient instructions on an outpatient appointment for later surgery. These consultations are very free. Speaking of which, the phone's ringing, and guess what? It's my main rival, internal medicine. Hey Bill, how is the kids? Just kidding, I don't care. So I have a patient with bleeding per rectum, and I'd like you to see the patient. Well, did you check if the cause is local, like in the skin or deep? No, of course not. I'm too sterile to put my finger in his. Anyways, so after the rounds, Bill goes to the operating theater to prepare the patient, Kate, for hernioplasty. Bill performs the surgery, keeps Kate in the ward for a few days just to observe the patient if there is any complications immediately after surgery, and if nothing goes bad, then the patient can go home. And now it's already 1 p.m. So Bill goes to his snack stash, which every surgeon has. He gets that sugar up, and he goes to the clinic. Every surgeon has a clinic where you see the non-urgent or elective cases. You will see a variety of patients with variety of complaints. Some of them has simple abdominal pain that you need to do full investigation for. Some have some chronic abdominal swelling like a hernia that requires surgery. Others can be treated with conservative means like some laxatives or blood thinners or whatever. In any case, in the clinic, you will see many patients, some of them requiring surgery, and those will be planned as elective cases later on, and some will be simply discharged from the OPD. Now, the work itself varies from one hospital to another, and it also varies greatly from one location to another. These parts of the world have more hernia surgeries, these parts have more lab chole, and so on. Some hospitals have more clinic days, others have more surgery days, some hospitals have a lot of patients during the rounds, and others have very few. And that's one day in the life of a general surgeon. Are you cut for it? Thank you so much for watching. Which medical specialty do you think I should cover next? I believe the top contenders are emergency medicine, maybe interventional radiology, or perhaps vascular surgery. I don't know. Just tell me your thoughts.